Good morning, everyone. The topic of my presentation today is theories of depression, and my moderator is Dhyanisi. So, today in this presentation, we'll be going about the various biological theories and psychological theories of depression. The psychological theories of depression will be just touching upon, and biological theories we'll be discussing in detail. So, let us first start with the psychological theories of depression. So, first of all, let us discuss about the cognitive theory of depression, which was given by Aaron Temkin-Beck at the University of Pennsylvania. So, according to him, people who are susceptible to develop depression, they have various cognitive distortions or they have various distorted ways of thinking. Now, these distorted ways of thinking, they develop from their childhood experiences. So, basically, what he said was, just look at this flow chart. So, in childhood, supposingly there's a child and the child has faced a bad childhood, parental neglect and sexual abuse and physical and verbal abuse. So the child may feel that the child he or she is not lovable or he or she is not intelligent enough. So they develop a core belief, which is also known as a schema, that they'll never be able to do anything good in life. So now they assume this, like they develop this assumption, and these core beliefs or these schemas, they lie latent until they are activated. So now what will happen is whenever there will be any life situation, anything, for example, the child now feel in like when he or she becomes an adult, they come into a relationship, they'll first, like anything bad happens, they'll have this automatic thought that I am not lovable, or for example they fail in an exam, I am not intelligent, because of the core schemas that had developed during childhood. Now these automatic thoughts, they will further they'll further affect their behavior, or their behavior as in they'll feel more depressed, more anxious. So this is the cognitive model of depression. Now, Aaron Beck also gave the cognitive triad. So, this cognitive triad, as we all read about ideas of hopelessness, helplessness, worthlessness, that there are negative views about oneself, that I am not lovable, I am not intelligent. Negative views about the world, this world is futile, nothing is good in this world, and negative views about the future, I'll never be able to change myself, nothing good, I'll never get like better, nothing good will happen. So now what can be these cognitive distortions? So various cognitive distortions have been defined. For example, let us look at overgeneralization, forming conclusions based on too little or too narrow experience. For example, I failed in class 12. I'll never be able to pass in an exam. For example, someone goes through a breakup. I'll never be happy. Like everyone is the same. No, magnification and minimization, over or undervaluing the significance of a particular event. For example, like magnifying your shortcomings and minimizing your good things. Then personalization, tendency to self-reference. Like parents, they personalize everything, that they blame on their upbringing, that their child has turned out to be like this. Then specific abstraction, focusing on a single detail while ignoring the others. For example, in this presentation, if all are listening and one is sleeping, so I'll think that I'll just focus on that. That the presentation is very boring because someone is sleeping. Then arbitrary inference, drawing a specific conclusion without sufficient evidence. For example, I spill milk while boiling in the morning. So if I cannot do such a small task, how can I do anything else in life? Then now, let us come to the Albert Ellis ABC model of depression. So Albert Ellis, he gave the ABC model. So according to him, good mental health is the result of rational thinking, and depression is the result of irrational thinking. So according to this ABC, A stands for activating event, B stands for belief, and C stands for consequence. For example, any activating event is there. For example, while coming to the college, I say waved hi to a friend and she ignored me. So I think that she ignored me. So what will be the consequence? I'll be like activating event was seeing this friend. Belief was that she ignored me. Consequence will be I'll never talk to her again. So she is ignoring me. Now this is the rational thinking. Now rational thinking would have been she did not see me. Maybe she was busy. So the consequence that I'll go and speak to her. So this would be rational thinking. So this was given by Albert Ellis, and he also gave the rational emotive therapy based on this. Now the another one was learned helplessness model, which was given by Seligman and Mayer at the University of Pennsylvania. So what was so here this Seligman and Mayer, they were basically trying to study the classical conditioning on dogs. So initially what they were doing was they were like putting dogs in a cage which was enclosed with no route to escape. Now in that case, light electric shocks were given. Now before the electric shock, like a light was shined or a bell was rung. So what happened was that gradually when electric shocks were given to the dogs and light was shined, so the conditioning developed. Now when shocks were not given and only light was shined, so they had basically conditioned and they behaved as if shock was given to them even though no shock was given. So they had conditioned this response. Now they took the experiment further, and what they did was, now these dogs, they were put into the cage like this with a fence in between. So now here this part was electrified and this part was not electrified. So now when a dog was put in this, and even though now in the previous experiment there was no route to escape, here now there's a route to escape. Now when electric shocks were given, the dog did not escape, basically because it was thought now the dogs have learned helplessness, that they cannot help themselves. They, like, even though there was a way out, they did not go, that they had learned to be helpless. Now in another cage, like in another set of dogs who were not previously conditioned, so they took those dogs and they put them into a similar cage, and they saw that those previously unconditioned dogs, they tried to escape. So this is how they explained the learned helplessness model. Now, Martin Seligman postulated a trait of learned helplessness, a belief that it is futile to initiate personal action to reverse aversive circumstances formed from the accumulation of past episodes of learned helplessness. For example, we can also see in this picture, there's like the baby elephant tied to this wire rope. Now the elephant, when even though it has grown in size, it can easily pass this, but he has learned to be helpless. Now, moving on to the more important part, the biological theories of depression, which we'll be focusing upon in detail. So now, what are the brain areas? Let us first discuss about the brain areas which are involved in depression. So we all know that in patients of depressions, everything is seen in negative light, and the access to memory is also negatively biased. So we can see here that somewhere hippocampus and amygdala are involved. So everything is seen from a negative emotional perspective. Now, gradually over time in depression, there is also cognitive impairment. Like there is poor focus, and abstract thinking is also like impaired. So we can see that somewhere the prefrontal cortex, the VMPFC and the DLPFC, they are also involved. Then we know that in depression, that there is anhedonia. There is like no loss of pleasure to any previously past pleasurable activities. There's loss of mood reactivity. So somewhere the neural circuits which are involved in the anticipation of the rewards, like something good will make them happy, that is also affected. So the nucleus accumbens and the limbic system, that is also affected in depression. And the basal ganglia. Now in depression, there is psychomotor retardation, lack of spontaneous activities. So somewhere the basal ganglia is also involved. Anterior cingulate cortex is also involved. We'll see how. So these are the brain areas involved in depression. Now, what are the monoamines involved in depression? So we know about monoamines, catecholamines, epinephrine, norepinephrine, dopamine. Then we have serotonin, histamine, acetylcholine. So the main monoamines which are involved in depression are norepinephrine, serotonin, and dopamine. Now, norepinephrine, we all know the cell bodies of neurons of norepinephrine are located in the locus ceruleus, which is situated in the brainstem. Now, this locus ceruleus, it is physically active, as in that whenever there will be there will be perception of novel stimuli, newer stimuli, so it will be more active, and during times of sleeping and eating, it will be less active. Now, locus ceruleus, it has a role in limbic arousal and cortical arousal, and emotional memory and behavioral sensitization to stress. So basically, this basically means that when there is chronic stress, so in scenarios of chronic stress, there is overactivation or like prolonged activation of locus ceruleus. And when locus ceruleus is activated almost like for a long period of time, there is behavioral sensitization to that stress. And also, norepinephrine has role in goal-directed and reward-seeking behavior. So basically, there is a medial forebrain bundle, which is the norepinephrine pathway to the anterior cortex. Now, when there is like chronic arousal, like chronic activation of this median forebrain bundle, so its activity goes down. So the goal-directed and reward-seeking behavior also goes down, which we see in depression. So this is the locus coeruleus, which is located in the brainstem. Next, we have the next monoamine is serotonin. Now, serotonin, we know it is like the cell bodies are located in the dorsal raphe nucleus in the brainstem, and serotonin has role in regulation of sleep, appetite, metabolism, body temperature, and it also has its neurons to the suprachiasmatic nucleus, which controls the circadian rhythm. So this is the dorsal raphe nucleus with its projection like everywhere to the cerebellum, to the cortex, and next is dopamine. Dopamine, we know it comes from the substantia nigra in the midbrain, and it is implicated in positive and negative symptoms of schizophrenia. And there are various classic dopamine pathways we all know of: the mesolimbic, mesocortical, tuberoinfundibular, and the nigrostriatal pathways. So these were the monoamines involved in depression. Now let us come to the classical theory of depression, or the monoamine neurotransmitter theory. So this is the most unsophisticated theory, or it is also known as the chemical imbalance theory, that it says that depression is due to deficiency of monoamines. That somehow we do not know how the normal amounts of monoamines are depleted by some unknown mechanisms. Now, this also coincides, basically correlates with the antidepressant drugs which we give, the SSRIs and the SNRIs. Like they increase the levels of monoamines and hence they improve the mood. Now, like gradually over time, the focus, it basically shifted to the monoamine neurotransmitter themselves, to their receptors, and to their downward signaling, their gene expression, their growth factors, and so on. So then came the monoamine receptor hypothesis. So according to this hypothesis, that there is monoamines are basically depleted. Now, when monoamines are depleted, there is upregulation, compensatory upregulation of these postsynaptic receptors. Now, this basically coincides with the basically whenever we give antidepressant drugs. So the antidepressant drugs, they lead to elevation of monoamines, but we see that the antidepressant effect, the effect on the mood, it comes after some time. So it is said that this time correlates with the down regulation of receptors. But there is no clear and convincing evidence for either of these theories, for either the monoamine neurotransmitter theory or the monoamine receptor theory, that how they occur. Next, we come to the glutamate hypothesis. Now, glutamate, we all know it is the major excitatory neurotransmitter in the brain, and it acts on the NMDA, N-methyl D-aspartate receptors, which are most abundantly present in the hippocampus. Now, it is said that we'll be studying further about the HPA axis and how hypercortisolism occurs. Now, glutamate works in conjunction with hypercortisolemia, and this hypercortisol levels, like the increased cortisol levels and the increased glutamate levels, they have neurotoxic effects. Like it has been shown in studies that these neurotoxic effects of glutamate include atrophy of certain parts of cerebral cortex and decrease in the volume of the glial cells. Now, it has also been seen that sub-anesthetic doses of IV ketamine, which is a non-competitive NMDA antagonist, it can exert rapid antidepressant effect lasting for 3 to 7 days, but it has psychomimetic and dissociative effects also, so it is not used. Now, another theory, let us come to the leaky gut hypothesis, or the brain-gut axis. So basically, it has been said that in depression, there is microbial dysbiosis. What is dysbiosis? That is alteration in the composition of the microorganisms which are present in our gut. So let us look at this. So basically in our gut, we have trillions of microorganisms. We have bacteria, fungus, viruses, and many more. So it is said that in depression, the composition of this microbiota of the gut is changed. So increase in the pro-inflammatory microorganisms occurs, like bacteroids, Enterobacteriaceae, and decrease in the anti-inflammatory microorganisms occurs. So there is a like state of inflammation in the gut. But now it basically, it is not very clear that whether this dysbiosis is causal to depression or it is a consequence of depression. It is not clear. It is said that it is a loop. Now, let us look at this theory, this axis. So basically, we have our gut is also known as the second brain. We have the enteric nervous system. Now we have an axis, the gut-brain axis and the brain-gut axis, which is like bidirectional. So the connection between the gut and the brain, it involves three routes: the immune route, the nervous route, and the endocrine route. So first of all, let us look at the immune route. So as I mentioned that in depression, it is said that the pro-inflammatory or microorganisms increase, and this leads to like the disruption of the homeostasis of the gut, and the gut microbiota and its metabolites. What they do is they disrupt this intestinal epithelium. So when this intestinal epithelium is disrupted, there is translocation of these the pro-inflammatory ones, the gut microbiota and its metabolites, to the peripheral systemic circulation. Now, here in the peripheral circulation, there is a state of inflammation and it leads to the release of interleukin-6 and TNF-alpha and so on. Now, this systemic inflammation, when it further crosses the blood-brain barrier, it leads to neurotoxicity. Now, neurotoxicity as in there will be like demyelination, loss of synapses, and so on. And further, it will lead to activation of the HPA axis, the hypothalamus pituitary adrenal axis. Now, when the HPA axis will be activated, we know from the adrenal gland there is release of cortisol. So cortisol will be released and it will further add on to the inflammation. And then so this was the immune and the endocrine one. So also it is said that the vagus nerve has role in like the vagus nerve. Basically, it passes on the inflammatory messages from the gut to the to the brain. That is all what it is. So this was the leaky gut because the gut was becoming leaky here, or the gut brain axis. So this was the leaky gut hypothesis. Now let us come to neuroplasticity and neuroprogression. So basically, whenever for example, there is early life stress, there is inflammation or genetics. And so all these things, inflammation, stress, environmental effects, they lead to they lead to epigenetic changes. What are epigenetic changes? The changes which occur in the DNA, that is methylation and histone modification. And these epigenetic changes, they lead to turning off for the genes for BDNF. Now, BDNF is the brain-derived neurotrophic factor, which is a growth factor, and it has roles in neurogenesis and neuroplasticity. Now, when there will be less of BDNF, it will lead to lack of synaptic maintenance, loss of synapses, dendritic arborization, and ultimately leading to loss of neurons themselves. So, for example, in this picture, we can see that BDNF, basically, loss of BDNF will lead to death of neurons, and BDNF is there. And so now let us come to another model, a very important model, which is the stress diastasis model, or the HPA axis dysregulation. So first of all, let us see what is the HPA axis. So HPA axis, we know the hypothalamus, anterior pituitary and adrenal, HPA axis. So from the hypothalamus, there is release of cortisol releasing hormone, and which acts on the anterior pituitary gland to regulate the adrenocorticotrophic hormone, which further acts on the adrenal glands. As we know, we have the cortex in the medulla. The medulla releases catecholamines, norepinephrine, and noradrenaline, and from the cortex, cortisol is released. So this is the HPA axis. Now, hallmark of the mammalian stress response is activation of the HPA axis. So, for example, whenever there is stress, so basically stress is more like stress induces a threat-like state, or a fear or anxiety-like state. Now, how depression comes in is when there is a anticipation of the loss due to this threat. Then depression sets in, when we try to find out the meaning of this loss. So the hallmark of mammalian stress response is increased HPA axis activity. Now, this activation of HPA axis activity can be due to an increased drive from the norepinephrine, okay, or it can be from cortisol releasing hormone, as we just saw, or decreased feedback inhibition from amygdala and hippocampus. Now, neurons from the amygdala and hippocampus, they basically they keep the HPA axis under control. Now, whenever there is increased amount, like there is chronic stress, the neurons in the amygdala and hippocampus are damaged. So the inhibitory control over the HPA axis is lost. So there is activation of HPA axis again. Now, the HPA axis, the end product is increase in the cortisol levels. So hypercortisolemia, as I just mentioned before in the glutamate hypothesis as well, leads to neurotoxicity. Now, let us also study about the dexamethasone suppression test. So dexamethasone is a synthetic glucocorticoid which is administered from outside. Now, dexamethasone, when it will be given from outside, the body will receive glucocorticoid from outside. So there will be a negative feedback mechanism and the suppression of the HPA. So this is normal. But what was seen that in patients of depression, dexamethasone, which was given at 1 mg at 11 p.m., it will fail to suppress the cortisol levels the next morning, which should have occurred in a normal individual, but this did not occur. But it is not diagnostic, as it is non-specific, because it is also seen in dementia and eating disorders, but it has prognostic value as non-suppressors have increased in the severity of depression and more relapse. So this was the HPA axis dysfunction. Now let us come to the HPT, hypothalamus pituitary thyroid axis. Clinical hypothyroidism is frequently associated with depressive symptoms, and subclinical hypothyroidism is commonly reported in treatment-resistant depression. Studies suggest clinical benefits of T3 as an augmentation agent with antidepressants in patients with major depression who have not responded to antidepressant monotherapy. Now, another thing which was studied was the supraphysiological doses of levothyroxine in mood disorder. Supraphysiological dose means more than 150 mcg per deciliter. Now, it was seen that these supraphysiological doses, they were efficient in reducing depressive symptoms, rapid cycling, prophylaxis resistant bipolar patients, and for patients with refractory monopolar or bipolar depression. Now, despite its efficacy, the use is limited by the sparse number of long-term studies investigating its tolerability and potential somatic side effects. A risk factor for developing, also we know that such high doses of levothyroxine acts as a risk factor for developing osteoporosis and increases risk of cardiovascular events like tachycardia, atrial fibrillation, high output cardiac failure, systolic hypertension, hence it is not practiced. Now, the hypothalamic pituitary gonadal axis. So we'll be studying about the ovarian hormones and the testicular hormones. So considerable clinical evidence demonstrates that fluctuations in ovarian hormones are associated with increased risk of depressive state. So we all know about the premenstrual dysphoric disorder, PMDD. Now it has been seen that during the luteal phase of the menstrual cycle, when the progesterone levels they fall, so there are more of mood symptoms which are seen in females. Also, these mood symptoms have also been seen during the postpartum periods and the menopause when the hormonal levels are less. So oral contraceptives have long been linked with the potential to alter mood. There has been significant controversy over whether they worsen mood, improve mood, have more complex mood effects, or are mood neutral. One study showed that oral contraceptive use is associated with an increased risk for subsequent antidepressant treatment, depression diagnosis, and suicidal acts, with significant risk for all hormone preparations. Now, hypothalamus pituitary gonadal axis testicular hormones. Now, depressive symptoms are common in men referred with borderline testosterone levels, and middle-aged non-depressed men in the community with low testosterone levels have higher likelihood of developing depression. The bulk of the evidence suggests that testosterone does not have efficacy in treatment-resistant major depression as an adjunct to antidepressant, and its routine use would not be clinically appropriate. So this picture basically shows here we can see the menstrual cycle and the HPG axis and this steroid hormone synthesis. Now, coming on to the broken circadian clock. It is also said that depression basically occurs due to broken circadian clock, or the circadian rhythms are dysfunctional, dysfunctioning of the circadian rhythm. So it has been seen that there is flattening of the daily body temperature, elevation of the cortisol secretion throughout the day, reducing melatonin secretion that normally peaks at night. Numerous genes that operate in a circadian manner sensitive to dark light rhythms are known as clock genes, and it has been seen that there is abnormalities in these clock genes that have been linked to mood. Now, what are the sleep changes associated with depression? They include increase in the nocturnal awakenings, reduced total sleep time, increased core body temperature, blunted growth hormone secretion, terminal insomnia, which is seen in typical depression, hypercortisolism, and increased REM sleep, reduced REM sleep latency, and increased REM sleep drive. So these are the sleep changes which are seen in depression. Now coming on to the role of inflammation. So it has been postulated that depression has a underlying subtle systemic inflammation. Mood disorders are associated with chronic low-grade systemic inflammation. Increased plasma levels of pro-inflammatory mediators targeting all tissues, including the brain. Importantly, pro-inflammatory cytokines like the TNF-alpha, interleukin-6 regulate mood behavior and cognition by influencing neurotransmitter levels, activating stress response endocrine axis, which we discussed. And pro-inflammatory cytokines may aggravate short-term mood changes to chronic maladaptive depressive state by preventing normalization of mood after adverse life events. Now, pro-inflammatory cytokines, they can lead to decreased production of BDNF, as we just mentioned, the brain-derived neurotrophic factor, which has role in, it is a growth factor. Then pro-inflammatory cytokines increase oxidative stress. Increased oxidative stress may compromise monoamine synthesis by depleting tetrahydrobiopertin, which is a coenzyme in monoamine production. Also, there can be increase in the enzymatic activity of indolamine 2,3 dioxygenase, leading to increased breakdown of tryptophan and decreasing serotonin. Now coming to the final part, the brain networks which are involved in depression. So it has been seen that the two brain networks, default mode network and the cognitive control network, they are involved in depression. The default mode network, basically the default mode network is active during the resting state, self-referential thinking, autobiographical thinking, daydreaming. Now it has been seen that in depression, there is hyperconnectivity in this network, which predisposes to negative recall and ruminations. Another network is the cognitive control network. The cognitive control network facilitates control of affective arousal and suppression of negative effects along with the anterior cingulate cortex when novel problems are encountered. Its connectivity is seen that it is diminished in depressive disorders. It has been seen, and it may contribute to relapse and reoccurrence. These are my references. Thank you.
Implications beyond psychiatry, it will also be psychiatry. At one time, widely researched. There's some points of precision that is solved. Yes. But it's patient determined. Can you please go back to Albert Ellis, that activation?
Yes, sir.
How it is different from CP. So we learn a lot about CP.
So Albert Ellis, basically, he gave the ABC model. According to him, there's an activating event, and like we have a belief which is associated with that event, and everyone has different beliefs. So this belief basically corresponds further like this. Any students? Our way of thinking. Yes. And the consequences that the thought which will basically will act upon the behavior which is associated with the thought. Yes, sir. So, for example, as I just mentioned that, for example, when I was coming in the morning and I saw a friend, I waved at her So this was the stimulus, this was the activating event.
Okay.
Now she did not wave back at me.
Okay.
The belief, so my belief was that she ignored me. She does not want to talk to me. So this is irrational thinking. Or and the consequence of which can be I'll start thinking that she does not like me, or that she's trying to ignore me, she does not want to speak to me. This is irrational. Now if my belief would have been, for example, maybe she did not see me, she, the consequence would have been I will go and try and talk to her, that maybe she's yes. I will also ignore that.
Talks to her and
Yes,
that is the
consequence.
This will now build up.
Yes,
That friend will not she does not know that what happened. How is it different? And if you put it in terms of CBT, how it will be? What will CBT?
so basically we will
There's a
work.
stimulus
Yes, sir.
and there is an automatic thought.
Thought. Yes, sir.
There is an automatic thought
That
that she does not like.
yeah, yes, yes,
Here, the intention is automatic. CBT will work on automatic.
automatic.
thoughts. What can be other thing?
Hmm.
There you work on the rationality, there you work on the
Automatic.
what's the difference?
So here we are working at that particular event, but there we are working at the core beliefs or schemas. Hmm.
It's like you would tell the person that what could have happened. They would be like, oh, this is last question. What was it for? And there be any other possibility that you so the approach is
Hmm.
this is more correct. There is some confusion automatic thought. Okay, you know,
Yes.
CBT. In fact, core beliefs सबसे last one. Then we work on the automatic thoughts. है ना? Identify the automatic thoughts.
Yes.
When you start the therapy, search for automatic. These are the easiest.
Yes.
And then you find a series of automatic thoughts that you are able to decipher the beliefs. Basic, what is the basic hypothesis is that every emotion is connected with a thought.
Hmm.
Okay. You can't change your emotions. Like if somebody is sad, you can't ask him just to be happy.
Hmm.
That is not. Don't worry, be happy. But how can he be happy? So he can change the thoughts.
Hmm.
The emotion is attached with thought. You change the thought, you change the emotion.
Hmm.
You find out what is the underlying thought. Okay, and how is that thought being produced? We try to change that process so that different thoughts are produced from different emotional states. That is the so your remark. Very is a psychological biological EBC का जैसे टीचर ABC का इसमें लोग क्या इंटरवेंशन
So
क्या करते हैं
yeah, rational emotive therapy is based on this, which also, so then A, B, C, D, E is also there. After A, B, C, then D is disputation and E is effective response. Basically, disputation is we are working on that belief, and then E is emotional response to it is changed.
that affects how the person is. And then the person may feel depressed but is still coming to work impairment in work. But it can rise to a level where then it affects the behavior also. So you target the behavior that is the existing behavior in the emotional उनको हमने पढ़ा है ऐसा biological theory से तुमको क्या लगता है एक काम करता था क्या है क्या करता है प्रॉब्लम कैसे काम ये नेपकिन बहुत लॉक्सफुली काम करता है तीन नेपकिन काम करता है बेसिकली दे आर
Yes.
physical exercise
Increases the level of endorphins in the body.
No comments. So
It also affects our the students it needs also which means disorder. It also facilitate students with iron
that was
the daily
stimulus. Set of stimulus that affect your right. So you get up early, you take a cup of coffee, or you do activities that want to do certain things. Like somebody is still talking to spouse, they will break up or divorce, and now the back to new time that change. Where existing problems are there. What else? What happens to REM? REM in depression? Right. Please be considered. REM. So, what else? What happens in REM? तभी डिप्रेशन वाले बहुत बोलते हैं बुरे सपने आते हैं.
excessive dreaming and negative ruminations.
So NREM, there is dreaming occurs all the time. NREM dreams is
Do not.
and if a person wakes up in NREM, most of the time is groggy, he's confused, and he has no tendency to go back to sleep. REM, he wakes up. Okay, and then you remember that he will die in dreaming on back. And antidepressants, what do they do?
They decrease the REM
They decrease
duration of
REM,
sleep.
they decrease the frequency also.
Yes.
They have that effect on the sleep uptake. Genetic major global topic. That India single gene transmission. Because there is that polygenic quantitative trade model, which suggests that with all these contribute a very small part for the so there is what is genetic mechanism, which suggests that various gene interactions. And so there is also psychodynamic theory of depression, which suggests that the disturbance in the infant and mother relationship at the oral phase leads to the depression. And so there is also object loss of modulus. Right. That is very significant older theory of
Yes.
object loss.
So,
Bereavement. So bereavement results in like that the depressive reaction is a bereavement reaction. So you learn from that. child. There are a number of theories, I think, that Russell did not good job. I will your comments now about the presentation and topic if you have any questions. Good presentation, although very exhaustive. But there are two chapters, I think, in comprehensive archaeology, anthropological, non-comprehensive. So biological is there, psychodynamic is there. So there's vast literature on this. And please to prepare a long question, you can get biological theories. And so I asked Prasa to skip on the psychological theories and focus only on the biological. We can have one.
Psychological.
So lead on the psychological theory. Right. All the theories also have some interventions. So let's see that most of the interventions work that way. Depression is chronic inflammatory disease. So earlier on, if thinking was it is a single episode and it ends and then person goes back to normal. But so studies are there that in a single episode of depression can have lasting effect on the brain on the population. And it tends to be what we see in clinical practice also, a vaccine waning disorder, chronic disorder. And so this theory that it is a chronic inflammatory disorder of the brain is also there. There are a number of biological markers that are associated with depression. Then there is also this thing that SSRIs, which act and they are using treatment of depression. So they can be anti-inflammatory. At the cellular level, they can affect the inflammatory response. One of these things was also brought to light when in COVID phase, patients who were receiving SSRIs, particularly fluoxamine, they had lesser mortality than patients who were not on antidepressants. So this theory that antidepressants may be acting not only through serotonin but through anti-inflammatory responses are also there. So we have number of theories and not one of them is specific to the disorder. Most likely what we see clinical depression is a syndrome, just like congestive heart failure or jaundice, which earlier people saw as one disease 50 years, 70 years ago. We thought of it as one illness, and then we found a number of etiologies for that, and then we found that one disorder, but a number of etiologies. Similarly, clinical depression, which we see at times, so it can be a mixed bag. There can be more than one etiology, so more than one hypothesis made in time with. And we see that many times you see a patient in severe depression fitting all the criteria, and it is just like a biological. One of the anecdotes that I heard is that she was one female patient, she was in severe depression, her child had gone abroad, and when he came back, just after 4 days, all the depressive symptoms removed, and he took her, and then she was in remission for a long period of time. So that object loss of bereavement, that also works at non-pharmacological methods. We should pay attention to that also, because many times simple interventions can also be right. That's it. Thank you. Rounds.